Now we will go to all these technologies one by one. And first, of course, we are going to start with the Smile from the Carl Zeiss platform. And here we have someone who has been one of the pioneers and also has done a significant amount of research, especially in the Smile technology. So let's welcome Dr. Sri Ganesh to talk to us about long-term outcomes and the latest developments in the Smile. Over to you, Dr. Sri.
Thank you, Vardhaman. Good morning, dear friend. So let's look at SMILE, the long-term outcomes and latest developments. I've been using SMILE from 2012, over 20,000 procedures done, and I was involved in development of the VISUMAX 800, and we got the first system in India. So I would like to share my experience. I'm a consultant for Carl Zeiss. So to look at SMILE, it's been a safe and effective procedure for correcting myopic astigmatism, and now more than 10 million procedures have been done worldwide by over 2,500 surgeons over the past 13 years. So it's the longest time that this platform has been there, and the longest experience. So the VISUMAX 500 was approved for myopia in 2016 by the FDA, and for myopic astigmatism in 2018. The FDA approval covers myopia from -1 to -10 and astigmatism up to 3 diopters. The 800 was launched in 2021. Development started in 2015, and this is a second generation femtosecond laser for lenticular extraction. So let's look at what is different in the VISUMAX 800. It features two arms, a swiveling laser arm and swiveling microscope arms, and there is no attached bed unlike the 500. So this improves the workflow and mobility. It also reduces the footprint. The pulse frequency has been increased from 500 kilohertz to 2 megahertz. So the lenticule creation time has come down from 30 seconds to less than 10 seconds. And this results in lower incidence of suction loss, better comfort for the patient, and a faster procedure. It's got some automated tools which assist the surgeon, like the center align for centration and ocualign for cyclotorsion compensation. So it helps surgeons to center the treatment both for sphere and cylinder, and it improves the precision of the outcomes. So we did a study to evaluate the visual and refractive outcomes in SMILE in a cohort of 1,500 eyes. So the first 1,500 eyes with the VISUMAX 800. So this is the workflow. After draping the eye, we just put in the speculum, and you can see those are the swiveling arms. The laser arm descends. You select the treatment, and then you put in the PI on the gantry. Rotate the joystick clockwise to lower the laser arm. It's got a side and top view camera which helps center the PI on the cornea, and the patient looks at the green fixation light, and then you put on the infrared light, and then you get the centration guide, which is the central line, which is basically a lollipop. So you can bring the centration onto the visual axis. So this is very important in patients with large angle kappa, so that you're centered on the visual axis. Then you put on the suction, and once you put on the suction, then you have the cyclotorsion adjustment, the ocualign, and now it's an automated cyclotorsion. Before we had to mark the cornea, now it's a markerless system, and then it automatically detects the iris pattern and compensates for static cyclotorsion. The laser itself takes less than 10 seconds. Here you can see that it's very fast, 8 seconds, because of the 2 megahertz frequency. And it's done. Then the laser arm goes up and the microscope arm descends. And then if you look at the bubble pattern, it's very nice and uniform. There's no OBL, and you get a very smooth dissection. And so that's the actual time it takes to dissect. This is the standard technique. I also have a technique called lenticuloschisis, where it takes lesser time to extract the lenticule. So this was the methodology. Study design involved 1,500 eyes. The inclusion and exclusion criteria was standard for lenticular extraction. A detailed ophthalmic assessment was done, including slit lamp examination, tomography, dry eye assessment. Surgical protocol was standardized, including laser optimization and settings. The surgical procedure steps were standard, using a Reinstein dissector to remove the lenticule, and Post-op care was tapering steroids over 1 month, and we did the statistical analysis. So you can see 1,500 eyes of 770 patients, and if you look at the spherical, the age was about 27 years on an average, so younger patient group, and spherical equivalent minus 4.17, average cylinder of minus 0.79, average central thickness of 534 microns. And if you look at the intraop parameters, we selected zones from 5.8 to 6.5 millimeters depending upon the refractive error and the pupil size. We used cap thicknesses of 110 or 120 microns, and we had a mean RST of 328 microns. So this was the pre-op and the post-op visual acuities measured at day 1, 15 and 3 months. You can see that the uncorrected visual acuity on day 1 was 0.03 logmar, and it improved to 0.048 by 3 months, which is excellent. And the spherical equivalent pre-op was minus 4.170. First day post-op minus 0.12, and at 3 months 0.025. And the sphere, if you look at the sphere, it reduced from minus 3.77 to minus 0.025 at 3 months, and the cylinder from 0.79 to 0.001. So very accurate corrections for cylinders. The OSI's pre-op were 0.733, and at 3 months it was 0.844. This was the objective scatter index measured with the HT analyzer. So this is the efficacy index, the uncorrected distance visual acuity. 98% of the eyes had 20/20 or better, which is an excellent correction with an efficacy index of 1.23. This is the change in corrected distance visual acuity, which gives us the safety of the procedure. 72.4% had no change in best corrected vision, 18.4% gained 1 line, and 9.2% lost 1 line. There were no eyes which lost more than 2 lines of best corrected vision, so the safety is quite good. So uncorrected visual acuity, same or better than corrected distance visual acuity, was 80.8%, and within 1 line of corrected distance visual acuity, 98.9% at 3 months. This is the difference between uncorrected distance visual acuity and corrected distance visual acuity in Snellen lines, and again you can see that corrected distance visual acuity 80.8%, same or better, and 98.9% within 1 line. 3 months post-op, again 0% loss of 2 lines. This is the attempted versus achieved graph scatter diagram, and you can see that 99% of eyes had spherical equivalent within half a diopter, so excellent refractive accuracy. 100% were within 1 diopter at 3 months, and if you look at the scatter diagram, the R square is 0.996, which is excellent, a very tight distribution over the central line. This is the stability of the spherical equivalent. You can see that from post-op day 1, where the refraction was minus 0.01. At 3 months it was minus 0.03. So percentage change more than half a diopter was 2.87. So the stability is good at 3 months. We followed up some of the eyes up to 1 year. So this is the astigmatic graphs. 98.4% had astigmatism within half a diopter, and 100% were within 1 diopter. So excellent visual, the refractive astigmatism correction. The scatter plot of surgical induced astigmatism versus target induced astigmatism showed correction well within 1 diopter in the second chart, and this is the rotation. So 91.9% were exactly on axis. This is the subgroup analysis, where we analyzed the based on the myopia. we looked at low myopia, moderate myopia, and high myopia. And if you look at the efficacy, 99% and 98% showed uncorrected distance visual acuity, 0 logMAR or better in low myopia and moderate myopia, and in the high myopia, 95% showed an uncorrected visual acuity of 0 logMAR or 6 by 6.
Okay, don't say that.
And at safety, the safety graphs at 3 months, loss of one line was seen in 7.6% in the low myopia group, whereas 9.6 and 10.8% lost one line corrected distance visual acuity in the moderate myopia and high myopia group. So moderate and high myopia group had lesser safety. If you look at the spherical equivalent between the groups, 99.4% and 100% of eyes in low myopia and moderate myopia group showed spherical equivalent within half adapter, and in the high myopia group, 95.8% within half adapter. So comparing the groups, low myopia, moderate myopia, and high myopia, the efficacy indices were 1.01, 1.009, and 1.014, and safety indices were 1.09, 1.08, 1.08. Again, not statistically significant difference between the groups. Spherical equivalent, 98% of eyes showed uncorrected distance visual acuity of logMAR 0 or better, and 8.9% lost one line in the, this is the comparison between the younger age group and the older age group. In the younger age group, so 98% of eyes had 20/20 or better, 88.9% lost one line. In the older age group, 96% showed uncorrected visual acuity of 0 or better, and 12.2% lost one line. So younger age group did better in terms of safety and efficacy. So what is very interesting is the objective scatter index and comparison of OSI over time in different groups. Sorry. So in the high myopia and the old age group, the day 1 OSIs were 1.83 and 1.94, which was actually significantly higher. It reduced at 3 months, but even at 3 months, you can see the old age group, the OSI is 1.33, much higher than the younger age group, which was 0.71. So older age, when you do lenticule extraction, the recovery takes a longer period of time. This is the 12-month data and we were able to analyze the 12-month data for 384 eyes, and the results were kind of similar. These are the graphs. For paucity of time, I will not go through this. To conclude, the VISUMAX 800 with the centration guide like the central line and the cyclotorsion adjustment features like the oculine showed safe and effective outcomes for treatment of myopia and myopic astigmatism in a large cohort of 1,500 eyes. This is the next international meeting, which is the 37th APA-CRS being held in August in Ahmedabad, and I invite all of you all to register and attend this meeting. Thank you very much for your attention.
Yeah, thank you, Dr. Sri.
If there are any questions, I can take them because I have to leave for a flight.
Okay,
Yeah.
Dr. Rupal ma'am has one question, please ma'am. Yeah.
Yeah, it's slightly high. It's of one line. Yes, but see the loss of best corrected vision of more than 2 lines is significant, because one line you can have differences if there's some amount of dry eye, or if the patient is not kind of very attentive and attempting to read. So one line loss of best corrected vision is not as significant. If it's 2 lines or more, then it is significant. But you will have some amount of loss of best corrected vision with most refractive procedures. There's a small percentage that's probably because of the induced aberrations or dry eye, which can be there.
So one comment from
I
Dr.
think,
Titial sir also. Yeah.
Sri Ganesh wonderfully compiled cases and study, and the outcomes has been really good. I think if you have experience of both 500 and 800 now. Do you think 800 has given you better outcomes in terms of the refractive outcome and patient satisfaction?
Refractive outcomes, not much of difference, especially if you know how to align the laser and also manually do the cyclotorsion compensation, which we described in the JRS. But in terms of patient comfort and patient satisfaction, it is better because the time is shorter And again, it is not as claustrophobic as the 500 because the arms come in and then go out. So we also looked at patient preference, and there is a slight increase in the patient preference towards the 800 when you compare it between the 500 and the 800. Otherwise, if you look at results, the results are very similar.
Any difference in the recovery time in these cases, 500 versus 800?
There's no difference in recovery.
No difference.
Sir, excellent presentation, sir. So have you experienced that the black spots in Visumax 800 are much easier to dissect when you have black spots in 500?
No,
I have experienced this, that if you have black spots with 800, somehow it's smooth to dissect even the black spots. Of course, not a big patch or something, but
if
it's
you have
easier
black
probably.
spots, it shows that there is an obstruction
Yeah,
to the
definitely,
laser.
that is there.
There is an obstruction to the laser either because of meibomian secretion or dryness on the surface. There is something which is blocking the laser, so you have black spots. If you have black spots in the center, please don't attempt dissecting it because you will get irregular astigmatism and loss of best corrected vision, whether it's with the 500 or 800. If there are small black spots in the periphery, you can still do it. I don't find much of difference, but in fact, I feel that dissection is smoother in the 500 in my machines, even after laser optimization, because what happens with the 800 is the laser arms move. When the laser arms move, the optics can get slightly shifted. And the accuracy is like about 20 microns, but even if there is a 20 micron shift, sometimes you can have laser pattern that is not absolutely smooth. So if you look at the 500 and 800 laser patterns and the variation in the laser patterns, the 500 is much more reproducible, the laser pattern, compared to the 800, though the difference is not much, but I think that it's because of the moving optics that you can have a little bit of difference, but of course for clinical outcomes there is no difference. And black spots, I didn't find any difference in terms of dissecting, and there should be no difference as such.
So, can I ask a question?
Sure.
Okay.
Do you have a time?
Yeah, please.
Sir, one thing you mentioned is the elderly age group has different outcomes. So we had looked at the lenticule profiling molecularly of different age groups. We know that people will get older, their changes, these are not too old patients also. But what we found was there are definitely extracellular remodeling proteins which becomes different when you grow older, and we compared it with the kind of dissection.
See,
So
what I feel is,
that means
continue.
just to complete on that, so I feel that your observation is very right, because the higher level of those proteins, that means it is making it to grow, change more, remodeling is going to happen, and that's probably the reason why one of your slides mentioned that there might be change in their outcomes, slower
Yes.
recovery or something.
See, I don't do lenticule extraction, whichever platform, in patients over 38, 40, because the recovery is delayed. Though they may have 6/6 day one, they are not very happy with the vision if you do it in a 40-year-old. So I prefer to do LASIK. The reason is because with age, the cornea gets cross-linked. The Bowman's also get stiffer. So when you actually do the dissection of the lenticule, the cross-linked fibers, which are stiffer, they don't kind of collapse. They cause more irregularity of the interface and more scatter. Even the Bowman's, the microfolds, because it's less elastic with age, you can have more microfolds, and this causes more scatter. That's why that you see that the OSI is significantly higher, and it also, even at 3 months, it's not as good as the younger patients. And even in the multicentric trials which we did with the 800, we had a patient cohort of 26 years, whereas in Europe the average age was about 34 years or something like that. And the day one recovery in our patients was much better than the other cohorts in Europe, because the European patients, the average age is higher. So lenticule extraction is very good for young patients. For older patients, again, the recovery is delayed. So this is something that you should tell patients. And again, it varies with different platforms. And this is even if you optimize the energy. With the Visumax, yes, even 35 to 40 years, it's still okay, the recovery. But in other platforms, if they're more than 32, 33 years, I don't really recommend, because then the visual recovery is pretty slow.
Thank you.
Surgeon is standard, but then the platform and the age, because age is something, because the biomechanics and corneal healing, as Dr. Rohit said, is totally different between young patients and old patients. Of course, this is a clinical experience, but I think he can do more work in the grow lab with all the molecular signaling and pathways and see what exactly happens in these lenticules.
Thank you.
Thank you very much. Thank you.